Hello, everyone. This is our presentation on ethical dilemmas of physician-assisted suicide in palliative care. My name is Rosalie, Bashir, Dinar, Giolina, Olivia, and Sophia. And these are a table of contents. We're going to discuss the introduction, cultural and social implications, strategies, and conclusion. For the introduction, palliative care is a specialized type of medical care that focuses on providing relief from pain and other symptoms. A team of professionals works with the patient to help provide support and care. Physician-assisted suicide is when the patient requests the physician to provide a prescription that ends their life, a prescription which they self-ingest or through euthanasia. Physician-assisted suicide is also legal in 10 US states, and these are the states that are highlighted here.
Physician-assisted suicide, or PAS, brings together three key ethical considerations. Patient autonomy emphasizes the right to make personal decisions about life and death, serving as a central argument for PAS. However, medical responsibility challenges this, as physicians must balance their duty to do no harm with honoring a patient's request to alleviating suffering. Advocates for PAS highlight compassion, viewing it as a human response to the physical and emotional pain endured by terminally ill patients, aligning with the goal of end-of-life care. Next slide, please. In 1997, Oregon passed the Death with Dignity Act, making it the first U.S. state to legalize physician-assisted suicide. Under this law, patients must have a terminal illness with a prognosis of 6 months or less, be mentally competent, and voluntarily request the medication. Key data highlights that 91% of patients cite loss of autonomy as their primary reason for choosing PAS, followed by 90% mentioning it as an inability to enjoy life activities, and 75% noting a loss of dignity. These reasons underscore the deeply personal nature of end-of-life decisions. Next slide, please. PAS raises significant ethical questions. On one hand, it supports patient autonomy, allowing individuals to make deeply personal choices. On the other hand, it challenges the physician's role in preserving life and protecting vulnerable populations. Ethical decisions must also account for cultural values, informed consent, and the potential for coercion. Ultimately, PAS reflects a delicate balance between individual rights and societal responsibilities. Next slide, please. Looking beyond the US, we see how PAS is approached globally. In the Netherlands and Canada, laws offer broader access, sometimes extending beyond terminal cases. These practices highlight cultural differences in how societies value autonomy and the sanctity of life. Globally, PAS raises questions about equity in access to end-of-life care, the impact of public trust in healthcare, and how ethical norms adapt to societal needs. By comparing international approaches, we can better understand the broader implications of PAS in shaping healthcare policy and ethical practices. Next slide, please.
In 2023, 93.8% of individuals who are receiving palliative and/or hospice care received the California's End-of-Life Option Act.
So I will be talking about the social and cultural factors. In Western societies, including the US, many individuals highly value their autonomy. This perspective often supports the view that patients should have the right to choose the manner and timing of their death, particularly when suffering becomes unbearable. In contrast, many non-Western cultures emphasize communal and familial decision-making. For instance, in many Asian cultures, decisions about end-of-life care are often made collectively by the family rather than the individual, which may conflict with the concept of PAS. Next slide, please. So here we have religious implications. We have highlighted some traditions. So for example, in Christianity, many Christian doctrines oppose PAS, citing the sanctity of life and the belief that only God has the authority to end a life. Similarly, in Islam, PAS is generally prohibited as life is seen as a trust from God and human beings are not entitled to end it. In Buddhism, some interpretations emphasize compassion and relieving suffering, which could support PAS. However, the principle of non-harm may oppose intentionally ending a life. And lastly, in Hinduism, attitudes towards PAS vary, but traditional beliefs often discourage it due to the karmic implications of prematurely ending a life. Next slide, please. Socioeconomic inequalities. So in the US, disparities in access to palliative care can influence attitudes towards PAS. Individuals, for example, who cannot afford quality palliative care may view PAS as their only option to escape suffering, raising ethical concerns about equity. And in low and middle income countries where palliative care services are often limited or unavailable, PAS may be considered as a last resort rather than a genuine choice. Next slide, please.
So I'll be talking about the legal and political context. In the US, PAS is legal in a limited number of states such as Oregon, Washington, and California under strict conditions. These laws reflect broader societal debates about the balance between individual rights and societal values. Globally, countries like Belgium, the Netherlands, and Canada have legalized PAS or euthanasia under specific conditions, often emphasizing the importance of patient autonomy and informed consent. In contrast, PAS remains illegal in most countries, where religious and cultural values heavily influence legislation. Next slide, please. To continue on to this point, I'll be talking about stigma and social norms. In many cultures, suicide, including assisted suicide, carries significant stigma, which may deter individuals from considering PAS even if legally permitted. In the US, advocacy for quote-unquote death with dignity laws has helped normalize PAS in states where it is legal, though it remains controversial. Next slide, please. And to further look into this, I'll be talking about global perspectives on PAS. So the United States debates center on autonomy and the rights of individuals to make decisions about their own bodies versus the physician's ethical duty to do no harm. In Europe, Belgium and the Netherlands, PAS and euthanasia are widely accepted, reflecting a societal commitment to personal autonomy and alleviating suffering. However, in the United Kingdom, PAS is illegal, with strong opposition from religious groups and concerns about the potential for abuse. In Asia, specifically Japan, cultural attitudes towards suicide, influenced by historical practices like seppuku, are complex. While not widely legalized, discussions about PAS are gaining attention. And in India, religious and cultural norms strongly oppose PAS, and it is not legally permitted. And lastly, Africa, PAS is largely prohibited, with strong opposition rooted in religious and cultural traditions that view life as sacred. To conclude these points, addressing the ethical dilemmas of PAS in palliative care requires acknowledging and respecting diverse cultural and social contexts. Policymakers and healthcare professionals must engage in culturally sensitive dialogues and develop frameworks that balance autonomy, compassion, and medical responsibility, ensuring equitable and ethical care worldwide. Next slide, please.
The Palliative Care Association guidelines helped create legal frameworks for PAS. And so the European Association for Palliative Care improved quality of life for patients with life-threatening illnesses, but they actually prohibited PAS, but allowed for terminal sedation, which a lot of countries have adopted. And the difference is that with PAS, the intention is to kill the patient and the outcome is death. Whereas with terminal sedation, it's different because the intention is to relieve intolerable suffering and the outcome is to alleviate distress. And so that this reframed allows physicians to more ethically relieve suffering kind of outside or as an alternative mechanism to PAS. The International Association for Hospice and Palliative Care established that PAS does not fall under palliative care obligations, so they kind of created that distance, and they spoke against it in circumstances. They also brought up the issue of conscientious objection, which would say that physicians have the right to not participate if they feel like it's kind of moving into the PAS side of things. The last guideline in the United States is the National Hospice and Palliative Care, and it discusses palliative as end-of-life care and creates kind of more legal language, about what suffering would qualify as. And so all of these models kind of work with the idea that intolerable suffering is patient-specific and reported, which allows patients to retain autonomy about what they can and cannot bear, and for that justification of PAS as kind of an ethical standard. On the next slide, it shows kind of a few landmark decisions that inform regulation. So the Netherlands expanded PAS to include not just terminal illnesses, but also spoke to people experiencing suffering, including psychological distress, which has raised ethical concerns about capacity. The Belgium Act emphasized the physician's role in ensuring compliance with strict procedures. So as a result, it created more regulations for physicians around PAS, which included medical board consultations, which many countries have adopted. The Switzerland model actually expanded PAS and allowed for people who were not from that country to come and obtain those services, which sparked question of like, glamorization of PAS. And Canada also actually said that it would be or not against their charter to prohibit PAS. So they allowed other countries kind of look at the issue legally rather than just from an ethical and moral decision-making point.
So what are some of the potential strategies to best address PAS? One way would be strengthening palliative care and pain management. For example, many patients seeking PAS do so because of insufficient relief of pain or psychological distress. Increasing access to the comprehensive palliative care services can actually reduce the demand for PAS by addressing physical, emotional, social, and spiritual suffering. One way we could do this is by increasing funding for palliative care programs, promote multidisciplinary teams consisting of doctors, nurses, social workers, and psychologists. Another way that we can do this is by having oversight committees, basically organizations that review PAS to make sure it's ethical, transparent, and free from coercion from family and friends. Next slide, please. Another way is increasing public awareness and education. For example, there's a lot of misinformation out there regarding PAS. If we educate the public on the full spectrum of options, including palliative care, hospice care, legal and ethical considerations, that could also potentially address PAS, and of course, early advanced care planning. And lastly, there can also be counseling and psychological support, including psychiatrists. Oftentimes, many of these patients have depression, fear of death, hopelessness, guilt, despair, and anxiety. And most of these diagnoses can actually be treated with medications. So if they are addressed, that can also potentially address the PAS. Next slide, please. And these are our references. Thanks for watching.